My topic is acute myocarditis. Are we missing the diagnosis? So, I have no disclosures. There's a recent study which showed the incidence of myocarditis worldwide has risen to a great level after 2019 just because of COVID 19, due to myocarditis related to COVID 19 or to the vaccine of COVID 19. A recent study published in 2025 compared the incidence in states and South Asia. In the above graph, you can see the mortality in United States has declined due to the myocarditis, while in South Asia, the mortality also has declined, but to a lesser extent. But when we see the incidence in the lower graph, the incidence in states declined up to 2010 and 15, but in 2020, it's again started to rise due to COVID 19. But the orange line shows incidence in South Asia. It has not changed in past 20 years. So is it really the incidence or it's been underdiagnosed? That's a big question. So myocarditis is a whole spectrum of symptoms. It can have no symptoms to a sudden cardiac death. You name a cardiac symptom and that can appear in myocarditis. So most commonly the patient who are admitted present with ACS-like symptoms. ECGs are not specific. Enzymes may be raised, may not be raised, may be highly raised, may be mildly raised. So there's a whole spectrum. Uh, in the patients with angina-like symptoms and normal coronaries, 5 to 13% have myocarditis. If we use CMR for the diagnosis, global burden is 4.2 to 8.7 per thousand population in young age, and 33% cases of MINOCA are actually myocarditis. So nothing is specific for the diagnosis of myocarditis on echo. Only if you find pleural pericardial effusion and some wall motion abnormality in a non-coronary pattern, then you might get a hint that it may be myocarditis, but clinical context is important. For those who do not have wall motion abnormality, strain can help. What is important is global longitudinal strain and regional strain. Global longitudinal strain, with a reduced global longitudinal strain, the prognosis is worse. Myocarditis can be hinted on strain by a problem in regional strains. But the problem with strain analysis is that global longitudinal strain is validated, but the regional strains are not. So we cannot have regional strains as a prognosis guide. So there's been a document in 2025, and there's some changes in the diagnosis and management. So the recent changes with the European guidelines is that we consider pericarditis and myocarditis as a whole spectrum, not individual diseases. So now we name it as inflammatory myopericardial syndrome, not myocarditis or pericarditis. Inflammatory myopericardial syndrome. They may be isolated pericardial inflammation, myocardial inflammation, or a combination of both. You name an etiology and it can cause myocarditis. You name a pathogen and it can cause myocarditis, viruses, bacteria, and parasites. But the important thing is non-infectious causes, which includes autoinflammatory and drugs. And chemotherapy obviously causes myocarditis. So in the center is genetic conditions. Always remember genetic predisposability to inflammatory myocarditis. Some of the highlighted pathogens are parvovirus B19, COVID-19 in recent era. Even the vaccination of COVID-19 can cause inflammatory myocardial syndrome. Bacteria, fungi, and protozoa all can cause inflammation. Autoimmune system like SLE, rheumatoid arthritis, and sarcoidosis all are inflammatory myocardial syndromes. Chemotherapy, and there is a new class of chemotherapeutic drugs which are immune checkpoint inhibitors, and they are notorious for causing inflammatory myocarditis. Still, there is a significant percentage of cases which do not fall under these and remain undiagnosed as far as the etiology is concerned. Regarding time course, it can be acute, it can be subacute, chronic, it may have remissions, or it may ultimately lead to inflammatory cardiomyopathy. So this is a busy slide. All I want to stress is any etiology which can lead to activation of innate immune response and the cellular adaptive response, as well as the antibody response, will lead to inflammatory myocardial syndrome. But in the center, the red one is genetic susceptibility. You have to keep in mind the genetic susceptibility for inflammatory disease as well. All those patients which have genetic mutations related to any of the cardiomyopathy are more susceptible to inflammatory myocardial syndrome due to any other pathogen. So how to investigate then? Up till now, we have seen the investigations are not so much useful. So coronary CT for angina-like symptoms or invasive coronary angio to rule out, and others are not specific. We go for biopsy or CMR in the clinical context. So biopsy, we do not just look for the histology. So whenever you have myocardial biopsy and you send it to the lab, do not just send as we send the other biopsies. You have to have histology and immune histopathology as well. They have to look for CD3 positive cells. And molecular pathology, you have to identify the pathogen in the biopsy. And systemic infection in blood, you have to identify that also, and also look for the mutations. This is the complete set of investigations that you have to do for the diagnosis. So biopsy can not only diagnose but also differentiate in various classical uh, uh, categories of myocarditis. One of those which I want to stress is giant cell myocarditis, in which there are CD68 positive cells and giant cells in histopathology. This myocarditis is very lethal, and it culminates into fulminant myocarditis very rapidly. Next one is sarcoidosis, in which we will have granulomas. The rest of those are more or less same, and the treatment does not matter in the upper three classifications. But in giant cell myocarditis needs aggressive management, and sarcoidosis has a completely different management. So, do we really need a biopsy? So we have a virtual biopsy, we call it CMR. So recently we have seen from 2013 to 2025, the paradigm has changed. There was no CMR in 2013, but in 2025, CMR is equally good as is biopsy. So for those who don't know much about CMR, uh, uh, what are the basic things that we look in CMR? First is the cine sequences. We look for the functional abnormalities. And then some images are T1 weighted. You can find them by different names as T1 scout or T1 or axial images. Then we have T2 images, which signify the presence of stationary water. We call it edema. You can have these images by the name of haste or T2 fat sat or stir images, in which we use fat suppression techniques to suppress the fat and enhance the presence of myocardial edema. And then we have post contrast images or PSIR images, which actually show the scar. So what we are going to look for is a bright myocardium in all these sequences. So T2 fat sat is a sequence which actually enhances the presence of myocardial edema, and bright is bad. So you can see the bright areas in the lateral wall of myocardium signifying myocardial edema. Same patient with T1 post contrast late gadolinium enhancement in the same areas signifying the presence of scar or fibrosis. So what we actually do is we combine three things: edema, necrosis, and capillary leakage. This criteria is called Lake Louise criteria, the original one published earlier. It combines presence of bright myocardium in T2 weighted images and early gadolinium enhancement and late gadolinium enhancement. So three things, two out of these three make the diagnosis. But there are latest advances which include T1 mapping and T2 mapping. These techniques do not require contrast administration, and they tell you the actual tissue properties with color coding. So the new Lake Louise criteria, you need one T1 based criteria and one T2 based criteria. Among T2 based criteria on the right side, you can have the previous which I've shown you, those images, or the mapping. In T1 criteria, you can have post contrast late gadolinium enhancement, or you can just have mapping sequences. So you need one of T1 and one of T2 to diagnose inflammatory myocardial syndrome. The next step after the diagnosing is you have to risk stratify. Certain findings make the patient at high risk. So dyspnea, fibrillation, AV blocks, syncope, and heart failure, all these make the patient a high risk and warrants admission. Intermediate category has some of those things, elevated troponin, non-sustained arrhythmias, while some can be stabilized and managed shortly in outpatient basis, which can be low risk. So after risk profiling, the last thing that has to be kept in mind is genetic susceptibility. As I've already mentioned, you look for genetic susceptibility and you also screen for autoimmunity. These two things are to be kept in mind and looked for meticulously. Finally, how to follow up. So rest of the ECG biomarkers and rhythm can be done as needed. Imaging myocarditis by transverse echo or CMR within first 6 months, the index imaging, and then after a year, and then yearly thereafter. What you have to see is you have to document, is inflammation there, it has subsided or not, has LV function improved or not. Similarly, similar is the imaging of pericarditis. So actually it is for both inflammatory myocardial syndrome. So take home messages, you should have a high index of suspicion to diagnose inflammatory myocardial syndrome. Only those patients who get admitted reach to the diagnosis. Most of the patients do not get admitted due to subtle symptoms and they do not get a full diagnosis. And second point is get a CMR. When there is a suspicion, get an early CMR and treat properly and follow them up properly. Thank you very much.